I've been following your amazing discussion, really highlighting the aspects, and I hope that this recorded live case of TTER will also show some of the aspects that you've been discussing. So, 85-year-old female patient, severe tricuspid regurgitation, obviously significantly symptomatic, had 3 recent hospitalization due to decompensated heart failure. You can see some of the comorbidities. That's a typical triluminate patient. So atrial fibrillation, female, some renal dysfunction. You can see the right heart catheterization. We perform this in every patient to have an idea of the pulmonary circulation, the pulmonary vascular resistance. So some moderate pulmonary hypertension, but the wedge pressure is not really elevated. Transpulmonary gradient is only 10. And you can see elevated right-sided pressures. The mean is 13 and the V wave is up to 24, but with good cardiac index and not a very high PVR. Euroscore is also borderline high. So this is the TE. You can see there's an atrial component that was discussed earlier on the mitral. You know, it looks like a prolapse, but it's not a prolapse. There's this whiff of central MR, and this is the tricuspid. As Elias and Michalis had highlighted, we scan the valve in this RVO view, the commissural view from posterior to anterior, from the free edge to the anterior, and we can see the quality of the leaflets. So it's a good case because you have this you have good leaflet length and mobility. There is some dilatation of the annulus, but really not a lot. So the leaflet to annulus ratio, which in my humble opinion actually works very well, is favorable here. And what was very interesting in this case, we didn't have a transgastric view. I mean, I tried when I screened the patient, Elias tried during the procedure, but we had a very good mid-esophageal view, and we implemented M-TEER on the screening process. You can see it's a true tri-leaflet valve with a septal, anterior and posterior, small posterior leaflet. So actually it's quite favorable anatomy with, as you can see, a central jet of severe, maybe massive tricuspid regurgitation. And this is the M-TEER in a close view. You can see on the top right the transgastric equivalent of the short axis view, and then you have on the bottom left, the RVO view, the commissural, and the long axis view, the grasping view on the bottom right. And this is how it looks on the bicommissural view, so significant mitral regurgitation. So let's have a look at the live in a box. You can see the insertion of the guide catheter through the groin. You can see on the top left the echo images, the fluor on the top right, and the table, and also some of the hemodynamics. So clip delivery system goes through. This is a tri-clip case, so clip delivery system goes through. It gets inserted on the stabilizer. And then once we get in a struggling position by monitoring, as you can see on the echo, we're going to flex down towards the tricuspid valve. We also use some of the L knob on the guide to get it away from the septum. And then flexion is pretty straightforward in these cases. There's nothing really spectacular about it. Once you have good orientation on the echo, it's quite easy to actually get down towards the tricuspid valve. You can see it only takes a few seconds. So a tricuspid TEER case actually is a little bit easier, at least in the first stage, because you don't have the transeptal puncture. Once your clip is in position, you can get your views right and get your orientation right. So we give a couple of minutes for the echo to settle. In our department is, as you mentioned earlier, a family business. So I'm really grateful for my cousin who is among you, who has taken a lot of bullying over these years in order to get the pictures very fast. But actually, I'm very grateful to him. And so what we did in this case is once we got our trajectory right, and you can see on the echo image on the right side, you have the long axis trajectory parallel to the septum, so we avoid any septal hugging. Perhaps I can show with a pointer here. This is the, I don't know if you can see my pointer. It's the long axis here. And then it's a matter of getting above the collar to get in the region of interest that is significant, and then opening the arms of the clip and getting the perpendicularity right. I'm just going to go a little bit faster here. Testing the grippers on the right side, and then getting the M-TEER view. So you can see on the M-TEER view, actually, we had a very good quality M-TEER view, and you can see we have a transgastric equivalent on the top right, the long axis on the bottom right, and of course the commissural view on the bottom left. And we were actually able to use this in live to grasp. So this is the gripper that is already on top of the lateral leaflet, and we swing septally. We also use the fluoro to make sure that we don't rotate, but in this particular case, we can also see the short axis. So you have all in one. And now we go up and the septal leaflet is in position. And once we drop the gripper, we correct the rotation of the system, and then we lock and we close. And we try to do that first time if possible. We don't like to open and close on the tricuspid leaflets. They're thin leaflets, so by doing as less as possible, you avoid injury. So now you can see we have a convincing grasping on the leaflets. And at the same time, you can see them both on the long axis view as well as the transgastric equivalent, like the short axis view, the bow tie sign that Ilias was referring to earlier on. This is actually very nice when you can get a good M-TEER view to do that in real time. Actually, it saves time. It saves a lot of effort from the echo to go to the stomach and backwards to orientation. And you can actually have, I mean, the resolution of the equipment we have today is amazing. And now you can see we've already had some reduction on the tricuspid regurgitation. Most of the anterior jet has gone. And we always check, of course, the leaflet insertion. We do all the regular checks, make sure we're happy, recording the grasping and reviewing. And you can see, and this is now a release of the clip to make sure that I'm just going to run it a little bit faster. All the steps.
Yeah, good idea.
Yeah. And so this is deployment of the first clip. You can see it stayed in position on the fluoro. And now second clip goes in. We want to put that a little bit more posterior to the first one. Again, similar steps like flexing down towards the tricuspid valve. We know that on the fluoro, that means that it'll have to be lower compared to the anterior clip. The posterior clip, again, we follow the same steps, trajectory and perpendicularity. You can see now we are on top of the anatomy. Again, we're setting the M-TEER views, making sure that we get all our axes right. The leaflets, the arms are open on top of the long axis view. And we're setting up our short axis view as well. So we have all in one. That's pretty straightforward. We can check our perpendicularity in the top right here. So you don't have to move to the transgastric view to do that. Actually, we didn't have a transgastric view on this patient. And once we're happy, we close the clip and then we dive into the ventricle. You can see it very gently by monitoring the relationship on fluoro. Fluoro actually helps a lot when you put the second device. Then we open under the leaflets, just under the leaflets. You can see the leaflets are already in position on the M-TEER. We're ready to grasp. So it shouldn't take that long now, going up, making sure that both leaflets are going in. And hopefully you will see the grasping in a minute. We need to make sure that both leaflets are in position. I think we dropped the lateral gripper here. We're moving a little bit more towards the septum. We prefer to go independent grasping on the tricuspid valve. It's a bigger anatomy, and you do this way, you do the optimization of the leaflets at the same time. So grippers are down, locking the clip and closing very carefully, all in M-TEER view. M-TEER actually, it was key in the success of this case. You can see also on the fluoro that the two leaflets are parallel to each other, so there's no relative rotation. And then we assess the result, and you can see it's a very nice result. We took care of the posterior jet as well. Both clips are adjacent to each other in the anteroseptal rotation, very close to each other, no gaps in between, no color in between. And after checking this is the deployment of the devices, and this is the final result. You can see the fluoro of these devices. And of course, hemostasis with a figure of 8. We don't use any proglide because it's expensive. So this is the final outcome. You can see there is some regurgitation, but clearly there is a reduction of 2+ or more in this from baseline to the final result. This is the baseline. It's always nice to go back to the baseline because, sometimes we need to get rid of these little whiffs of color, but, you need to have things into perspective. And what is interesting also is looking at the hemodynamics. Is this the right atrial pressure before? The V wave was 23, patient on sedation with a mean pressure of RA pressure of 10, went down to 8, mean pressure of 5.
Great. That was a terrific.
Thank you so much.
Thank you. That was a terrific imaging and hemodynamic result and very well explained. I'd like to have Dr. Leontiadis come up to the podium to get ready for present his live in box, okay, and at the same time make any comment, offer any comment regarding this first case.
Okay. Now the last case is from our hospital, Dr. Chatzitofi, on a patient mitral clip.